being able to look at x-rays and interpret whether we're seeing decay or perio. And in this case, we're going to talk about trauma, pulpal lesions, and periapical lesions. We're going to talk a little bit about the common features that we see with trauma, resorption, and pulpal and periapical lesions and how they look on our x-rays. Some of the trauma that we'll see are fractures, injuries, or possible displacement of teeth.
It says there was an error on my computer screen about pulling up your PowerPoint.
Is anybody else having that problem?
No, I can see yours.
I'm having the problem.
Okay. So was that Mariah?
Yeah, it just says cannot display content.
You might try to go out and come back in and see if you can. Are you on your phone or on your computer?
A computer. I can
Okay.
exit and come back.
Okay, because if no one else is having the problem, my guess is it's at your end.
Okay, I'll be back.
Okay. Okay, so trauma is an injury produced by an external force. This could affect the crowns, roots, or the alveolar bone of our teeth. And when that happens, we can end up with intrusion, extrusion, or complete avulsion. So we're going to talk about what each of those might look like. Fractures can occur in the crown, the root, or the jaw. And whenever a fracture is evident or suspected, images are necessary for us to identify that. Crown fractures most often involve the anterior teeth. And if you think about that, it's kind of for obvious reasons. Those front teeth get bumped pretty easily, whether it be from a physical fight, somebody's fist, or car accidents. And we used to see this a ton with kids and those stinking scooters and razors. So often we'd see them go over the handlebars of a bike or a scooter or those things and fall. And of course, your front teeth are going to be the first ones to go. So when that occurs, depending on how bad the break is, that could involve the enamel, the dentin, and the pulp possibly. And depending on that, if it breaks to where that pulp is exposed, a lot of times your patients are going to have severe sensitivity because now they've got raw nerve exposed to air, cold, hot, anything. So a lot of times they won't even be able to talk because the air that comes in just zaps them. So the image, if we take an image of that, it's going to allow us to evaluate how close that damage is to the pulp and the root for possible additional fractures. So most of the crown fractures, like I said, are involved in car accidents or falls. And this is what a crown fracture can look like. And on that one, it does not appear to be in the pulp chamber. You can see where the pulp chamber comes down, and it does not appear to be there. That doesn't mean this patient would not have sensitivity. Everybody is different. Sometimes if you're close to that, it can cause sensitivity. Root fractures, again, often occur in those maxillary teeth, and they can be a vertical fracture or horizontal. And we could see a single or multiple fractures depending on what type of injury that patient has sustained. Now, if our x-ray beam is running parallel to the plane of that fracture, then it's going to appear as a radiolucent line. It's kind of like when you guys look at the palate. You can see that mid-sagittal palatal, what do I want to call that? You know what I'm talking about. The line down the middle of the palate where it grows together looks like an itty bitty teeny tiny radiolucent line because it is an actual place where the bone separates just slightly. So that's what it's going to look like if you're able to get that parallel relationship to that fracture. However, if your beam is not parallel to the plane of the fracture, you might not see it at all. And so this is why sometimes when you go and you get x-rays, like little Miss Kelly had to do for her foot and ankle, there are so many tiny bones in the foot and where the ankle comes together. And again, if I don't have a parallel relationship with that fracture, sometimes it doesn't appear. So that's kind of the same way in the mouth. Just to showing you root fractures. And the ones that are really horrific sometimes is when they're vertical and run the length of the tooth. Okay, so jaw fractures. These obviously are more observed in the mandible, and I believe jaw fractures are more from physical fights where people get knocked in the jaw, or if they work around horses, say for instance, and get kicked in the jaw or things like that. So they're going to be more commonly seen in the mandible, and a panoramic image is going to be the best for visualizing these. Again, a fracture, if we're able to see it, is going to look like a radiolucent or dark line. Maxillary fractures are seen less often. And again, if we do see them, they're probably going to be in that anterior alveolar bone and teeth where people sustain injury often. And this is an example of what a jaw fracture might look like on X-ray. Injuries can result in the displacement of teeth. So we're going to talk about the different types of injuries. We can either see luxation, and that can be either intrusion or extrusion, and avulsion. Luxation is an abnormal displacement of teeth. So either that tooth has been knocked up into the socket and it's intruded into the bone, or it's an abnormal displacement out of the bone, which would be extrusion. I always think exterior and interior. Into the bone is intrusion or interiorly, and exteriorly would be out of the bone. So teeth that have been luxated should be evaluated by a PA to examine for root and adjacent alveolar bone fractures, damage to the periodontal ligament, and possible pulpal problems with that tooth. Here is an image of intrusion. You can see that tooth has been shoved up into that socket, and the picture on your right is extruded. And many times they will reset these teeth. They'll either push it back up into the socket and splint it, kind of like when we see lingual arch wires on ortho patients. They'll do that with these, where they'll put composite and a little bar to kind of hold it in place in hopes that the tooth will reattach. Many times the tooth will die from the trauma. So even if it does reattach, sometimes they require root canal therapy. Again, partial avulsion is very similar to, it's another name for luxation, but it would be exterior, like, hold on, let me show you. Extrusion. Okay, so avulsion means a tooth is completely displaced from the socket. So if a tooth is avulsed, it's knocked out on the ground, out of the mouth. So if we see partial avulsion, that's going to be extrusion. Those are the same, just so you know that we're talking about the same situation. A periapical image, again, is going to reveal a tooth socket without a tooth, and hopefully clinically you would be able to diagnose that too. Okay, resorption. We've talked a little bit about a resorption, and I think you guys have seen some of that maybe on some of our x-rays. We talk about external resorption and internal resorption. What is resorption? Resorption is when something resorbs or kind of goes away. So if we think about physiological resorption, this is seen with the normal shedding or exfoliation of primary teeth. So in order for those primary teeth to become wiggly, that permanent tooth pushes through, up through the roots of the primary teeth. And as it puts that pressure on the root of the primary teeth, those roots begin to resorb or go away. As the root goes away, the tooth becomes wiggly, exfoliates, and now that permanent tooth can come in its place. So sometimes if a tooth is knocked out prematurely, it'll take a long time for that permanent tooth to come in, because that primary tooth is kind of, I always think of it as it's kind of got a rope and it's tugging the permanent one up through. If that primary one is not there to tell that permanent one, hey, it's about time for you to come in, it's your time to take over, that permanent one just sits down there under the gum for a while before it decides to actually erupt. So sometimes we can see a delayed eruption pattern in teeth that have been lost too soon. Pathologic resorption is something that is due to an alteration of the tooth structure. It's that tooth has been subjected to some sort of stimulus that caused it to resorb. The most common that we see is orthodontic movement. Many times in adult ortho, if they move adult teeth too quickly, we'll see this occur at the roots. External resorption is going to be seen along the periphery of the root surface and is often associated with, let's say we have a tooth that's been partially avulsed or completely avulsed and we reimplant it. Abnormal mechanical factors like ortho, trauma can cause external resorption, because basically ortho is a trauma to that tooth, and that's why we're seeing resorption there too. Chronic inflammation, tumors and cysts, impacted teeth, and sometimes we don't know why. Sometimes we just see external resorption and we're not sure. But external resorption involves the apices of the teeth. They appear blunted. So we're going to see, let me see if I've got my picture up here. If you look at this lateral incisor, you can see that it looks like somebody just came through and filed off the apex of the tooth. That is external resorption. It is seen on the outside of the apex of the tooth. With external resorption, the lamina dura, which is the bony socket that holds the tooth in place, and the bone around that blunted apex appear normal. These cannot be detected clinically. You can't just look in someone's mouth and know they have external resorption. The tooth does not usually exhibit mobility unless it is severe, and there's no treatment for this. Internal resorption now occurs within the crown of the tooth or the root of the tooth, involving the pulp chamber, the pulp canals, or surrounding dentin. We're really not sure what causes internal resorption. They think it could be caused by trauma, or if someone's had to have a pulp capping or pulp capping procedure, or pulp polyps that were present. And what this is going to look like is, it looks kind of like a round or oval radiolucency in the middle of the crown or the middle of the root. How we treat this is we'll treat it with endodontic therapy or root canal if it has not perforated the root of the tooth. If it's perforated the root of the tooth, we have to extract the tooth. And this is what internal resorption looks like. If you looked at this x-ray and you didn't look in the mouth, you would think that's decay. But when you look in the mouth, you really don't see anything. It's really kind of odd. If the patient has recession and you can actually see the root, like the central incisor that you see on the right, sometimes that looks kind of pink, where the inside of the root, the pulp chamber, and all of that looks kind of pink when you're looking at the root on the outside. So basically, this is almost like the tooth is eating itself from the inside out. If this has not perforated the root structure, sometimes the tooth can be saved with the root canal, but sometimes, unfortunately, the tooth just has to be extracted. So now when we're looking at pulpal lesions on dental images, we're going to be talking about anything that has to do with the pulp chamber and the canals that house the nerve of the tooth. So with images, we can detect pulpal sclerosis, pulpal obliteration, and pulp stones. And I'm going to show you what those look like. Pulpal sclerosis, anything that is sclerosed is kind of hardened or filled in or calcified. So with pulpal sclerosis, we're going to see a diffuse calcification of the pulp chamber where it almost appears like the pulp chamber is getting smaller and smaller and smaller. And we see this with age. So if you looked at a tooth from an 18-year-old versus a tooth from someone who's 60, their pulp chambers at 60 are much smaller than the 18-year-old. And that's just normal calcification over time or sclerosis. This condition has little clinical significance. If it is a problem, they'll do root canal therapy if necessary. Things that can lead to this are attrition, abrasion, caries, dental restoration sometimes because that's traumatic to the tooth, trauma to the tooth, etc. So some things like that can stimulate the production of secondary dentin. And secondary dentin we'll learn about in histology and embryology. That is the dentin that your body, your teeth produce in the event they've been exposed to a trauma. So let's say you go and you have a large filling done, and for the first 3 weeks, that little guy is so sensitive to heat and cold and maybe even to bite on it. But you notice over time that sensitivity gets better and dwindles and finally goes away, hopefully. What's happening is your tooth is laying down extra secondary dentin that is protecting that pulp chamber. So that is what can occur in these cases. And in some cases, it can completely obliterate the pulp chamber where it fills in completely with dentin. And if you look at this tooth, number 8, and you look at the root of number 8 and compare it to the root of number 9, and you can see there is no pulp chamber anymore. There is no pulp canal anymore. I have a tooth like this in my mouth, one of my premolars in my 20s. They did a full mouth set of x-rays on me and it was already obliterated completely. Don't know why. It could have, I guess, been from the trauma of orthodontia, but I'm not sure. So anyway, that's what that might look like. And it doesn't have, like sclerosis, you wouldn't see it completely filled in. It would just be really, really narrow or really small up in the crown of the tooth. Again, obliteration is that production of that secondary dentin that completely obliterates the pulp chamber. In this case, the teeth are not vital because I no longer have any nerve. So there's no treatment necessary because you can't take a nerve out of a tooth that doesn't have any nerve anymore. So it's almost like it's kind of done a root canal on itself. Pulp stones are dystrophic calcifications found in the pulp chamber. These appear as little round, ovoid, or cylindrical radiopacities. So all of these things are going to appear radiopaque or lighter or white because they are more dense. Again, these stones can vary in shape and size, usually don't cause symptoms. No treatment is required. We just usually find them on x-rays. I've seen quite a few of them in our clinic. If you look at the lateral incisor on this image, you can see right where the pulp canal comes up and meets the crown of the tooth, that round ovoid looking radiopacity, and that's a pulp stone. Now, periapical lesions. These are the radiolucencies or dark areas that we see at the apex of a tooth. When something appears dark, many times that means that it is fluid-filled or air-filled. Some of the periapical radiolucencies that we will see are the periapical granuloma, the periapical cyst, or the periapical abscess. Also a periodontal abscess, which is a different cause. The first 3 listed there, the granuloma, the cyst, and the abscess, if I took an x-ray, they all appear the same. They all look like a periapical abscess, which is what everybody calls it when they see it on an x-ray. The only way you can really know what that is probably if you just had like a microscopic look at the cells. An abscess, however, is typically the one that's going to exhibit pain because an abscess has exudate or pus, And when that pus builds up inside and is not allowed to drain, it causes pain because it creates a lot of pressure. So the abscess is usually associated with pain. The other two, not so much. The periapical radiopacity that we're going to talk about are condensing osteitis. Again, osteo means bone, and condensing would be more dense. When something is condensed, it's like pushed together and super tight. So condensed bone or dense bone, sclerotic bone, which we just kind of talked about. And then we're also going to talk about hypercementosis, which is just kind of an overproduction of cementum on the root of the tooth. Like I said, periapical granulomas, cysts, and abscess are commonly seen. They cannot be diagnosed by their appearance alone. The diagnosis would be based on clinical features, probably a history from your patient, and microscopic appearance. So a granuloma is a localized mass of chronically inflamed granulation tissue seen at the apex of a non-vital tooth. So this patient's not going to have pain because their tooth is not vital. It results from pulpal death, or where the nerve is slowly dying within the tooth, or inflammation of the pulp. It can give rise to the cyst or abscess. The periodontal ligament space appears widened at the apex, and the lamina dura is not visible between the apex and the lesion itself. Remember, I don't know if I've shown all of you, but we've talked a lot about those mental foramen on our periapicals and how often they sit right near the apex of our premolars, and it would be very easy to think that was an abscess. However, if you follow the PDL down, that ligament space should appear radiolucent, and then that lamina dura should follow it and not widen around it at the apex of the tooth. So in this case, we don't see the lamina dura between the apex of the tooth and the lesion. It's widened because that infection has kind of taken over that space. Treatment for all of these is root canal therapy or extraction if it's too severe. So basically, most of the time they just call it an abscess because all three of these are going to be treated the same way. It really doesn't matter whether it's a granuloma, a cyst, or an abscess. The abscess matters because you've got active infection usually with exudate, and so that would probably require antibiotic treatment, but you would probably know that one. That one's going to have pain, or it's going to have a draining fistula where you can actually see the exudate draining from the area. If you look at this granuloma, follow the radiolucent periodontal ligament space, and you can see we get down to the root tip and it goes out and around the tooth we also don't see that white lamina dura anymore. The bone goes out and around with the lesion. The periapical cyst is also called a radicular cyst. Radicular means root. So the lesion will develop over a long period of time. This is the most common tooth-related cyst that we see. 50 to 70% of all the cysts in the oral regions are this periapical or radicular cyst. It's going to appear just like that image I just showed you of the granuloma. It is round or ovoid, and it's seen at the apex, and it results from pulpal death or necrosis, and it's usually asymptomatic. Again, we're going to either treat it with root canal or we're going to extract and curettage out that apical region of where that tooth was. This is a CT image of the cyst, and you can see this one has been allowed to go pretty far. It is involving the whole anterior portion of the mandible. So this is what we don't want to happen. We don't want patients to let their infections go to an extreme. And if this occurs on a maxillary tooth and the infection is allowed to go this rampant, it can actually begin to affect the patient's brain. The infection can spread all up into the skull, and people have died from that. So it is really important for patients to address infection when they have it. So a periapical abscess is, again, this one is the one that's going to exhibit pain in the acute form. It is a localized collection of pus or exudate resulting from necrotic or dying pulp within the tooth. If something is acute, it comes on quickly. If something is chronic, it is long lasting. So an acute periapical abscess, the pain is intense, throbbing, and constant. We usually see sensitivity to pressure. Percussion is when you tap on it or bite on it. And then heat is another one that we see with periapical abscesses. This may or may not appear on a dental image, depends on how quickly it's come on. Is the infection involved enough yet for us to actually see it on an x-ray? If someone has a periapical abscess that is a chronic situation, usually this is asymptomatic. And the reason it's asymptomatic is because it has that pus or exudate, but it has formed a fistula, which is just a channel through the jaw where it looks like a pimple. If you pull their lip down right in front of that tooth, it looks like they've got a pimple that needs to be popped. But it usually does on its own. It'll open and drain. Maybe the patient might say that they've noticed, or someone that is near to them has noticed an odor, and that's because it's infection draining in their mouth all the time. So that would be chronic. Now we're going to talk about a periodontal. Periapical means the apex of the tooth. Periodontal means down in the supportive structures of the tooth. So a periodontal abscess is different. That's a collection of pus or exudate that results from infection within the periodontal tissues. So within those supportive tissues of the bone. This can be a very acute, quick onset, destructive process. And it's a complication of advanced periodontal disease. The radiolucent area will appear on the side of the tooth or on the lateral aspect of the root, and it creates a deep throbbing pain. So what are we going to do for this patient? Usually in this situation, you're going along and you're doing your perio charting and you hit a 9. Okay, maybe the patient's 4, 3, 4, 3, 2, 4, and then you get 3, 3, 9. So you fall in this one deep pocket on one side of the tooth. So what we're going to do in that case is we're going to go in there and we're going to scale that area really good. If we need to, they can drain it. If there's a lot of infection in there and they have a way, they can drain that out. And we're going to debride those periodontal tissues. Sometimes we'll even try to get them on an antibacterial rinse like chlorhexidine. We'll flush that area out with a Cavitron, scale it to make sure there's nothing down in there causing trouble. And sometimes this can occur from like a popcorn hole that has worked its way down in the side of the tooth and kind of dissected the periodontal tissues away from the tooth. So we need to get in there and clean that out in hopes of getting some reattachment. So that's a periodontal abscess. So question, what is the difference between a periapical abscess and a periodontal abscess? The periapical abscess is a collection of pus that results from necrotic or dying pulp within the tooth. A periodontal abscess is a collection of pus or exudate that results from an infection within the periodontal tissues that surround the tooth. I'm going to continue. It's about 12:28. I've just got about 6 more slides and we'll be done with lecture. But if any of you have anywhere you need to be, I am recording this and this will be on YouTube. So I just want you guys to know, don't feel bad if you have to hop out. Okay, so common periapical radiopacities now. Pacities, remember, opaque is white. So these are going to be seen on dental images based on their appearance, clinical information, and a patient history. And the 3 that we're going to talk about are condensing osteitis, sclerotic bone, and hypercementosis. Condensing osteitis is a well-defined radiopacity seen below the apex of a tooth. Usually this patient has a long history of pulpitis. So they've had a tooth that has had pulpal infection for a long time. It's probably drained because people don't let painful things go on and on. If they've had a long-standing history of pulpitis, that tooth has probably had a fistula and has been draining infection. These can vary in shape and size. It does not appear to be attached to the root, but over time, the bone around it kind of almost heals itself and becomes really condensed. This is the most common periapical radiopacity observed in adults, and it is common in the mandibular third molar area, and no treatment is necessary. It's kind of filled itself in. If you look at these molars, you can see the radiopacity around the root of the tooth, and you can almost kind of envision what that looked like when it was pulpitis or when we did have infection or irritation in that area. All of that area kind of filled in with bone. Sclerotic bone, we've talked about sclerosis already, but sclerotic bone is now, we talked about sclerosis of the pulp chambers. Now we're going to talk about sclerotic bone that can occur in the bone of your jaw. So this is going to be, again, a well-defined radiopacity. It is also seen below the apex of vital, non-carious teeth. It is usually discovered just on a routine image, so there's no known cause. It's not attached to the tooth. It can vary in size and shape. The margins of this radiopacity can be smooth, irregular, or diffuse, and it's asymptomatic. Patient doesn't even know they have it. If you look at this image, you can see right under the premolar that white circle, that radiopaque circle, and it's just sclerotic bone. Nothing to be concerned about. There's no treatment necessary, and again, the patient isn't even aware they have it. Hypercementosis. This is a excess cementum production on the root surfaces. Teeth always want to find something to occlude with. So you guys have seen, we've had I think a couple of our full mouth sets that we've had you guys mount. There were super erupting teeth. And if you look at the root of a super erupting tooth, it probably has excess cementum because that tooth is trying to grow. And the only way the tooth can grow is to lay down more cementum, because that will make it thicker and push it farther out of its tooth socket until it reaches something to occlude with. So hypercementosis can result from supereruption. Inflammation can cause it, and trauma as well. One trauma that can cause it is bruxism. When we are clenching and grinding our teeth together, we are reducing the height of our tooth. And so those teeth want to stay in occlusion with one another. So those teeth will continue to lay down cementum to keep those occlusal surfaces touching. Hypercementosis most often affects the apical area of the tooth. It looks like a big bulbous growth, kind of. The PDL appears normal, and the lamina dura appears normal. These teeth are vital, and it does not require treatment. If you look at these roots, you can see how they look like a thick baseball bat. They just look really, really bulbous. And you can tell that the tissue that is on the root is not as dense as the dentin or the enamel of the tooth. And that's kind of how cementum appears. So you would know that that would be hypercementosis. All right, guys, that is